about clinical trial and the research of a possible treatment for Duchenne muscular dystrophy. I think that you have had already earlier on today a presentation on gene therapy. It essentially what this picture shows that we can divide all these approaches into different groups. You know, the ones that try to restore the dystrophin protein, and the ones who try to limit the progression of the dystrophic process, either by preventing muscle necrosis and fibrosis or increasing muscle regeneration. And looking at the genetic approaches, this is the very long gene of dystrophin, which encompasses 79 exons, as you can see here, one of the longest in our body. And we know that Duchenne is caused by a deletion, duplication, or mutation that essentially disrupt the reading frame of the dystrophin gene and lead to out of frame, cause out of frame of the reading, this reading frame, and those the dystrophin protein is absent in muscles. But because the Becker muscular dystrophy is a milder form, at least in terms of the muscle pathology, because in Becker muscular dystrophy, there are in-frame deletion or mutation that somehow allow the production of some levels of dystrophins in the muscle. Of course, one of the initial question was, can we try to transform or to convert a Duchenne boy into a Becker that has a milder clinical presentation? And one of the very first approaches that was tempted was the exon skipping strategy that essentially use antisense oligonucleotides that are very short sequence of oligonucleotides that essentially use the Watson and Crick base pairing rule by linking to the pre-mRNA, and as you will see, preventing some of the exons by being read from the machinery of the cells. So, for example, if we look at these 79 exons that compose the dystrophin gene, and you have a child who has a deletion between exon 47 and exon 51, of course, this leads to an out of frame. And if we try to skip or to jump this exon, and we try to link exon 46 with 52, this is what is called exon skipping, the reading frame of dystrophin can be restored, similar to what happens in Becker muscular dystrophy, essentially. These are here circled, the most commonly used, commonly investigated exon in clinical trial. And you see here a table that summarizes different antisense oligonucleotide exon skipping strategies that are currently under investigations. Some of these, especially eteplirsen, casimersen, golodirsen, have been approved in America, in the US, by FDA, while others are still under investigation. We have also now Viltolarsen, that is an exon skipping for exon 53. And you see here also other companies are developing a similar strategy. And you see here the data from the eteplirsen, for example, for exon skipping 51, and these are 5 years follow-up. You see that patients remain ambulant for much longer compared to the natural history. So these are data from control age-matched patients from the Synergy network in the US. And you see here also that the decline in the forced vital capacity, so the respiratory function, is also less pronounced compared to what happens in the untreated population, as you see here on the right side of this graph. And this is also similar data on Golodirsen for exon 53, the 3-year data, in which it is shown the lower decline on the 6-minute walk test compared to matched natural history controls. And these are patients still ambulant after 3 years on the medication compared to what happens in the natural history of the disease. So really promising data. Exon skipping altogether can target nearly 70% of the deleted patients. So this is really a strategy that, of course, is under investigation, because it could apply to many patients, and they are quite safe, honestly, so far. Some of the companies are trying to improve the biodistribution of the drug, because of course this requires weekly administration. Now we have some trials in which the patients come once a month because they are slightly improved, modified to improve the uptake into the muscle cells. So even monthly infusion are good instead of the weekly infusion. And of course, this can reduce the burden for the families and for the patients. In terms of regulations, as you see here, there are different approaches. For example, in the US, the FDA accepts restoration of dystrophin on muscle biopsy as a surrogate endpoint to demonstrate the effects of this medication, while in Europe, they want a more clinical endpoint. So they want to see a clearer clinical benefits to patients, and also they want to wait phase 3 studies with placebo arm. Another approach is ataluren for nonsense mutation that essentially improved the read-through at the ribosomal level to improve the functioning of the dystrophin protein. This is approved from EMA for patients with point mutations that lead to stop codon, so nonsense mutations, and is currently approved under a managed access agreement in the UK. So there will be shortly a review. The data on the long term show some promising results, but of course it's not always easy to have a comparators from natural history database for these patients. I think that you have already heard earlier on about gene therapy, and you know that, of course, different companies are pursuing these, but there is also additional work on the other aspect that is more related to limiting the progression of the dystrophic process. And we know that these corticosteroids act by reducing the inflammatory response and the immune response that on the long term lead to the fat replacement, to the damaged muscles where the dystrophin is lacking. And vamorolone was a steroid-like medication that was developed to reduce the mineralocorticoid effects, thus possibly limiting the side effects related to corticosteroids. And this was the VISION-DMD, that is the study that included essentially patients that were either on placebo or on prednisone for 6 months, or on vamorolone, either the low dose of 2 milligrams or the higher dose of 6 milligrams for 6 months, as I said. And then after a washout period of 4 weeks, all patients switched either to vamorolone, the low dose, or vamorolone, the high dose 6 milligrams for additional 20 weeks. And we now have the data, the results in terms of efficacy. This is the time to stand velocity, which was the primary endpoint. And you see that the vamorolone high dose, so the 6 milligram, was achieved the primary endpoint after 24 weeks compared to placebo. So the study met the primary endpoint. You see here in terms of other clinical endpoint, for example, the 6-minute walk test, the time to walk or to run velocity, and the time to climb, the North Star score. And you see that essentially in all of them, of course, the vamorolone compared to the placebo achieved all these endpoints. This is the difference between vamorolone 6 milligrams and prednisolone, because of course prednisolone is the main benchmark, you know, in this clinical trial. And you see that essentially at the end of the study, if we consider all the data altogether, they are quite similar. There is some mild difference probably in some of this, but we can say that in terms of efficacy, vamorolone is similar to prednisolone. The 2 milligrams probably is slightly less effective. You see here, you know, it's less, the 0 is what is the results for prednisolone, and is the comparator. So let's say that 6 milligrams compared to the 2 milligrams is as effective as prednisolone. These are the side effects, the adverse events of special interest. And for example, if we look at the Cushingoid features here, or the behavioral problems, you know, for sure, the vamorolone 2 milligrams experience much less of these side effects. Also, if we look at the weight gain, for some of them also vamorolone patients on 6 milligram had these some of these problems. But in terms of behavior, for example, in red we have the prednisolone. These were much more common in the prednisolone patients compared to those on vamorolone, even vamorolone 6 milligrams. And it's interesting here to look at the switchers. So the patients that were, for example, on prednisolone here for the first 6 months, and then they switched to vamorolone 6 milligrams. And you see, if we look at the behavioral problems, they dropped from 40% to 20%. Cushingoid features, they dropped from 20% to 6.7%, and the same for weight gain. So there seems to be some positive effect also for those patients who switch from prednisolone to vamorolone in the second part of the study. So in conclusion, in terms of efficacy, they are quite comparable, but possibly the safety profile might be slightly better for vamorolone. There is the possibility to reduce to 2 milligrams, especially if the patients experience additional side effects. One important thing is the adrenal suppression. We know that also patients on vamorolone can be at risk of adrenal suppression, because at the end of the study, we performed the synactin test, and many of them were in cortisol suppressed. So it's very important to alert the patients that this can happen. But for the rest, you know, also in terms of biochemistry, hematology, there were no main issues. Another trial that has just met the primary endpoint is the Givinostat trial, which is HDAC inhibitor, and has also achieved the primary endpoint. So might be something that we will hear about in the next few years. And in conclusion, of course, we need to be very good in making good diagnosis very soon. We need to follow the standard of care and try to improve the management of these patients. but also there is more optimism that some of these treatments can become available in the near future to improve the quality of life of these patients. Thank you. I'm happy to take any questions you may have. So going back to the question of vamorolone, you see that might be a good alternative. You know what I can tell you, and I think that this is self-explaining somehow. All the patients who participated in the trial were switched to compassionate use. So the company is continuing to provide the medication for free to these patients who were in the trial. And all of them wanted to continue to take vamorolone. None of them wanted to go to the other two steroids, either deflazacort or prednisolone. So I think that this already speaks about the fact that the families, you know, are happy to be on vamorolone. They are very concerned about, you know, steroids and the side effects. Having said that, of course, especially in terms of weight gain, we were expecting a little bit more because we have seen, unfortunately, weight gain also with vamorolone patients on 6 milligrams, as we see normally with prednisolone or deflazacort, but not all of them. So something that we need to bear in mind. Definitely, the patients grow taller. They don't have the stunt in height that we see in patients, especially with deflazacort. And we know that for teenagers, this is very important because when we speak with our teenager patients, you know, they say, I don't care, I don't want to be, you know, bullied because I'm short, I'm little. It's very important for their self-esteem, you know, the perception of their body. So even, you know, these aspects might be important to consider when we pros and cons for certain treatments.
Маргарита? Чи відомо, яка кількість таких пацієнтів?
Is it known how many patients like that in the UK take vamorolone all the time, constantly?
Yeah, so I don't know the total number. I think around 20 patients at the moment. Between 20 and 25 patients were recruited in the trial, not only in London, you know, in all the UK, and they are still on the compassionate use, and they are still taking vamorolone. And now Santhera, who has bought you know, the rights to commercialize vamorolone, has applied for approval at the FDA, and they are planning to apply also for approval in Europe to use vamorolone.
Скажіть, будь ласка,
Please tell us. We know that Neuromuscular Center in London is one of the best centers in the world in terms of diagnostics, treatment, and clinical researches in general worldwide. Please tell us, the patients in the UK, do all of them have this link and connection with your neuromuscular center in the UK? I mean, are all patients registered in your neuromuscular center, or are there separate hospitals in other parts of the UK and the patients of these centers never come to your center, and there is a separate treatment in separate hospitals?
So there are like 23, 25 neuromuscular centers in the UK, and we try to distribute the patients according to their location to their closest neuromuscular centers. we don't want patients to travel long distances because it's not safe for them, but also we try, to ensure that they can receive the best care locally instead of needing to travel several hours to achieve another center. What may happen sometimes is that, for example, not all the centers may have a neuromuscular physiotherapist who is trained for neuromuscular, or a cardiologist, or an orthopedic surgeon. So sometimes we accept joint management, so that, for example, patients come to us, let's say once a year, for a general review and also to discuss specific topics. So, for example, surgery or respiratory care or anything else, or physiotherapists, if this is not available in their local neuromuscular centers. But they try to come for specific queries, and sometimes we see them only ad hoc, like occasionally, like for single consultations, if they have specific queries, and then they go back to their local centers. Sometimes they come only for the clinical trials, because we have a database in which all the families in the UK can register to say, I would like to be part of a clinical trial, if there is any, and we can call them, even if they are not our patients. They are registered in the database, and we have a random extraction, so they can be picked up and selected to come to our center for the clinical trial.
Дякую. І ще я хочу додати таке, що у нас уже
Also, I want to ask the following. In March 2022,
ще були заплановані декілька
in March 2022, clinical researches in Kharkiv were planned, and
also we had several clinical trials scheduled for other clinics in Ukraine, but since due to the war, everything stopped. But we have a lot of physicians who want to acquire more knowledge in the field of trials and to work with neuromuscular patients, especially Duchenne disease. And we have parents who are ready to ensure that their child will participate in clinical trials. I would like you to take this to account and look on such an opportunity of training Ukrainian physicians in your neuromuscular center to be partners. And in turn, parents also are ready to go to any country so that someone will help their children.
Yeah, that would be very, very important and very interesting, actually. Yeah, we try to do the same also for other conditions, because I think that it's very important to involve several countries in the clinical trials, because hopefully there will be many available, especially using similar approaches from different companies, So it might be that we don't have the capacity in our country to take on all the clinical trials. So this is why it's very important to distribute and involve other countries. But to do that, of course, it's very important to build up the capacity in the centers to run clinical trials, because you need trained clinicians, trained physiotherapists, you need to have dedicated administrative support, because you have to upload the data into an electronic form that goes to the central lab. So it's very important to work on this. And it would be fantastic, if this is something that can be realized in the future. And definitely, you know, we will be happy to assist and support the training of the centers to say what you need, what you would require, you know, to run a clinical trial and so on.
Дуже дякую за
Thank you very much for accepting our invitation. Thank you very much for taking part in the conference. Oksana, the floor is yours.
Thank you.
Very much,
Thank you.
Professor
Thank you for
Baranello.
inviting me. Have a lovely rest of the day.